Alrighty guys, we're going to go over the second part of this class, which includes the heart and everything with it. So let's go ahead and get started. Pectoralis major. Pec major originates in the medial half of the clavicle, anterior surface of the sternum, including the lower half of the ribs, costal cartilage. It inserts on the medial side of the humerus in here. So his job is adduction. He will adduct, meaning he's going to bring the arm and add it towards the body. He's going to bring it medially. And he also immediately rotates. So picture yourself having your arms spread out as if you're going to hug someone, and you immediately rotate them. You bring your hand towards your abdomen. You're hugging yourself. So that's one thing he does. Most importantly, his prime movement is flexion of the humerus. What that means is you bring as your arms are sitting down by your side, you bring your arm forward anteriorly. That is flexion of the humerus. So like you're going to punch someone. So that's its major job. Now, one of the key features of this muscle is its innervation. It has two nerves that run through it, the medial and lateral pectoral nerves from the thoracic nerves. So, unlike his little brother Pec minor, this guy receives innervation from two nerves, medial and lateral. And of course, his blood supply is the pectoralis, the pectoral branch of the thoracostomy trunk, which is an artery that goes up and down here. That's minutia. The biggest thing is an innervation in its movement. Okay, as far as Pec minor, most importantly, understanding how he moves is very important to see why we call it Pec minor. So Pec major is basically flexing your humerus itself. Well, if you look, this guy's origination is on the actual third and fourth ribs on the anterior surface, and then he inserts up on the shoulder joint, on the clavicle as well as the scapula. Well, since he's pulling downwards towards the bottom, he helps depress the shoulder as well as protract the scapula, meaning bring the scapula anteriorly when he contracts. Now, one of the key features to this guy, unlike his big brother, is only the medial pectoral nerve innervates him. So what you will see is the medial pectoral nerve is going to be touching him, going straight through him, and then it's going to come and attach to pectoralis major, which is anterior to this Pec minor. So on the exam, one of the key features you need to know is what is the innervation to these two muscles. Pec major has two, both lateral and medial pectoral nerves, whereas Pec minor only has the medial pectoral nerves, and the blood supply is the same as his big brother. Last but not least, the other muscle of the thorax, besides the intercostal muscle and so forth, is the subclavius muscle. It's a very, very small muscle. It's found right underneath the clavicle. He originates around rib 1, between the rib and costal cartilage, and he inserts on the middle part of the clavicle, the third clavicle. So, it's innervated by the nerve to subclavius and actually supplied by the clavicular branch of the thoracostomy trunk, which is a large artery that's right here. Both these are not as important as what's important is his movement. This guy helps stabilize your shoulder joint. So this clavicle is the only bone that attaches your arm to the axial skeleton. So if it breaks or dislocates, the whole arm is useless, which is why this muscle is so important. He stabilizes the sternoclavicular joint, which is this joint right here between the sternum and the clavicle, to make sure this doesn't dislocate from the actual body and the arm is useless. Because of where he lies also, he can also depress the shoulder, just like pectoralis minor. Now, as far as the neurovascular supply, you need to remember that the intercostal nerves run underneath the actual ribs along with the intercostal artery and intercostal vein. They do have collateral branches like the collaterocutaneous, etc., or lateral cutaneous branch, which is the reason when we anastomose the rib, we have to go above and below to make sure that all the nerve is anesthetized. So the nerve runs underneath, the root always runs underneath the rib in that sense. Okay, as far as the intercostal nerve block, what's most important is knowing where to stick the needle. Since the root of the nerve the nerve roots run underneath the ribs. If you break the third rib, you'd have to go below the third rib and anesthetize that particular nerve itself. And then, of course, you have to go above and below, several ribs below and above, to make sure all the intercostal nerves and all the collateral branches are anesthetized so that particular rib won't hurt. One of the key features of Zari's exam is how many layers do you have to get through in order to get to this nerve. So if you look at this picture, you have the skin, you have the fascia, which is a layer of connective tissue lying over the muscle. You have the serraceous anterior muscles, which elevate the ribs. You have the actual external intercostal muscle, and internal intercostal muscle, and then the nerve. There is another muscle underneath that called the innermost intercostal, which is this layer over here, but you don't have to get to that to get to the nerve. So if they ask you, if I ask you in the exam, what layers do you have to get through to get to the nerve? These are them. So it's a high yield question for medical school, and you probably see it on your lecture exam nonetheless. Now, as far as the lungs, when you get air or fluid in the lungs, in the pleural cavity surrounding the visceral or between the parietal and visceral membrane, we usually have to do a thoracostomy in order to get that fluid or air out using a tube. So basically what you do is you go above and below the intercostal nerves, between that rib, between let's say the fourth and fifth rib or sixth and seventh rib, and then you suck the air, the water, whatever may be out. Now this latter bullet, this is going over some definition. So pneumothorax is when you have air in the pleural cavity due to trauma, anything like that. Hemothorax, heme is talking about blood in the pleural cavity in the space. Hemopneumothorax is when you have blood and air in here. Pleural effusions, we have fluid in here. Empyema is pus due to infection. You have pus surrounding here. Hydrothorax is water, and chylothorax is bile. All of these can compress the lung. So if you just picture fluid or air in here, it can compress this lung and then cause issues and push the heart towards the opposite side, which can also collapse the other lung. So what you have to do in order to fix this is you have to do a thoracostomy to get that air or fluid out of the lung. So typically you stick the tube at the bottom so you can drain all the air and the fluid from the bottom up. Okay? Now as far as arterial supply, one key feature you have to understand is on the ribs there is anastomosis, meaning the arteries communicate with one another between two arteries. So if you look, on the anterior side you have the anterior intercostal arteries, and they're rooting from the subclavian arteries. So the subclavian arteries are releasing the internal or anterior intercostal arteries in the front, and they're going to wrap underneath the rib on either side and feed the ribs from that side. Now, on the posterior side, the descending aorta, you have the posterior intercostal arteries, and they'll wrap around and feed the ribs on either side. So if you have a clot on either one of these, you do have a chance of having collateral arteries from either the anterior or the posterior intercostal artery to feed those ribs and those muscles to keep continuing to breathe. So it's an important feature about the arteries because the veins can do this too, which can also help. One key note that I want you to understand is if you look at this picture, you have an artery on the top of the rib as well as the bottom. So you do have collaterals. Now remember, below the rib is the primary artery, vein, and nerve. So it's called van. So you have the vein, the artery, and nerve in that order underneath the rib for that key feature. So the ribs are supplied by both anterior and posterior intercostal arteries. There is anastomosis, and the root is important. The posterior intercostals come from the descending aorta. The anterior intercostals come directly from the subclavian veins on either side. So that's an important key feature to remember, because you can imagine looking at the diameter, clots in either or, you can lose blood supply, but because of the anastomosis, you have collaterals which will help give blood supply to those intercostal muscles to help you breathe. Now, as far as the venous supply, key feature, all of these are going to drain into the superior vena cava nonetheless. So on the thoracic cage, you have a left venous supply and a right. On the left, the upper half, all the way from rib 1 all the way to roughly rib 5, you have the accessory hemizygous vein that's draining all those ribs and all those muscles on that left side. On the lower left side, from rib 5 or 6 all the way down to 12, you have accessory hemizygous. So that'll handle, so you have hemizygous. That'll handle the lower part. So accessory hemizygous handles the upper half of the left side. Hemizygous handles the lower half of the left side. They will both drain into the azygous vein here. And if you look, the azygous vein is also draining part of the inferior vena cava up to the superior vena cava. So this guy handles a lot of blood from both left and right half of the thoracic cage. And it even helps a little bit from inferior vena cava. So it can help drain some of that into superior vena cava right here. So all the intercostal veins, they're going to drain all directly or indirectly into the azygous vein, depending if you're talking about the left or the right. They drain indirectly into the azygous vein from the left through the accessory hemizygous or hemizygous, and the right side drain directly into the azygous vein through that. And the azygous vein drains completely into the superior vena cava. Alright, so this goes over the same thing I just went over. It's showing the blood flow from the hemizygous, accessory hemizygous, draining into the azygous vein. You can see there is some collateral from the inferior vena cava. The azygous will drain some of that, and they'll all come up and drain into the superior vena cava. The other key feature is the subclavian veins. Oh, sorry. The brachiocephalic veins are going to drain both the internal and external jugular veins and the subclavian veins from left and right half of the upper limb and upper neck and head straight into the superior vena cava. So the superior vena cava has two branches that come directly off of it. They're called brachiocephalic, left and right. And of course, they'll also leave off of the internal and external jugular as well as the subclavian veins. All these branches are going to drain to the brachiocephalic veins and the superior vena cava. Remember, all the venous supply is going to enter the right atrium, the heart, and we'll talk about that a little later. So remember, if you have a block in the inferior vena cava, which happens more often than not, believe it or not, especially when you have clots in the legs, and it gets blocked off somehow, you do have a beautiful little supply that helps drain that inferior vena cava to the superior vena cava to the heart. So there is some hope with the azygous vein. Excuse me. Okay. The lymphatic ducts. With every venous supply, there is lymph, and it's going to drain straight into the vena cava in one way or another. So in the thoracic cage, you see two ducts that drain the entire body directly into the subclavian veins. So the right lymphatic duct, this guy right here, he's going to drain into the right subclavian vein. The thoracic duct, also known as left, will drain into the left subclavian vein. And it's a one-way shot, one-way direction like veins. They also have valves like veins. So it's a one-way track. Their job is to get rid of all the garbage and stuff away from the body, including excess fluid, pathogens, etc., and get it to the bloodstream and keep all the pathogens in the lymphatic system and remove all the excess fluid into the venous supply so you can get rid of it and oxygen and so forth. So if you screw up these ducts or you screw up the lymphatic nodes, you can get edema. You can start gaining fluid in your body because it has no way of escaping. So let's talk about these two. And the right lymphatic duct is going to drain the right half of the body on the upper side. So the right thoracic cage, right face, right neck, including the right arm. It's all going to drain through the right lymphatic duct into the right subclavian, which means the rest of the body, the left side of the face, the left side of the neck, the left thoracic cage, the left arm, as well as the entire abdomen and the lower half, those lymph nodes or lymphatic vessels will drain into the thoracic duct. Particularly, it's going to enter through the cisterna chyli, which is a big glabrous sac, and then that will drain up the thoracic duct up to the subclavian vein. A key note, guys: the right lymphatic duct, you have to go to the right subclavian to see it. It's very small. It's about ½ an inch long, very tiny in length. You may not see it on your cadaver. The thoracic duct is so large and so long that you probably see it, and the way you know it, it's in the midline. From the inferior side, it's midline where the cisterna chyli is, and it runs upward superiorly and starts going to the left side to drain into the left subclavian vein. So it's very noticeable. I'll show it to you. It's underneath the esophagus, right above the vertebrae, anterior to the vertebrae. This goes over basically it's a visual of showing you where it's draining. So all the right half, right upper arm, right thoracic cage, right face, right neck, it's all draining to the right lymphatic duct. So if you have any edema on the right side, typically it's because the right lymphatic drainage is not working correctly, probably axillary lymph nodes, whatever it may be. So remember, it's a one-way track. So the lymph nodes drain from the periphery towards this right lymphatic duct. And the left handles everything from the left face, left neck, left arm, left thoracic cage, abdomen, pelvis, lower limbs. They're all going to drain up the thoracic duct straight into the left subclavian vein. Again, it's another one-way system. It starts in the periphery and drains towards the midline to the thoracic duct. This just shows you a picture where the thoracic duct lies. It's a better schematic. You can see its midline from the inferiors, and there's the cisterna chyli. So you can see the lymphatic duct also goes straight to the hiatus, and it's going to drain upwards into that subclavian vein. Alright, now let's get to the nervous system of the thoracic cage. I showed you on the cadaver the sympathetic trunks, or also known as sympathetic chains. On the neck, you saw them in the back of the neck, midline, away from the vagus nerve. Well, once you hit the thoracic cage, it's midline, it's near the actual vertebrae, and it's coming off the spinal nerves. So the sympathetic chain, if you'll notice, it goes all the way down to the pelvis. But in the thoracic cage, it's very important because it handles cardiac, pulmonary, mediastinal nerves, as well as splanchnic nerves that go as well as to the heart and lungs. So the splanchnic nerves handle a lot of the esophageal branches and so forth. So you'll get sympathetic to that region. The major key features I want you to understand is fight or flight. So in sympathetic, it's going to handle the heart and lungs. You'll increase your heart rate, increase your force of contraction of the heart. Remember, you are chasing me with a knife. I need oxygen to my body, so it's going to increase heart rate and increase force of contraction to get the oxygen to my body as quick as it can. It'll also dilate my bronchi and trachea because that will give me more oxygen to my lungs to oxygen my blood. So just remember that with the sympathetic. It's also known as cervical thoracic ganglion, which are on the chain. So all these nodes that you see there are ganglion. They're clusters of nerves that help delegate where the conduction needs to go, and so forth and so on. So the sympathetic trunk, also a sympathetic chain, runs from T1 all the way to L2 and handles all the thoracic cage and so forth. Now, your parasympathetic. It's a little more intricate. The vagus nerve handles both sides, and it handles parasympathetic all throughout the thoracic cage. And again, when we hit the abdomen, you'll see it also handles parasympathetic there too. So your vagus nerve on the right comes down, continues down the abdomen, down the thorax to the abdomen. So it's going to handle the esophageal plexus, the pulmonary plexus, and cardiac plexus on the right-hand side. So you can see it gives parasympathetic to the heart, the lungs, and the esophagus. On the left-hand side, it comes down on the the superficial side of the aortic arch, and continues down the abdomen. And key feature here, guys, look, here's your sympathetic trunk, and the vagus is medial to that. So you saw that on the heart. I showed it to you coming down. Sympathetic trunk is lateral to the actual vagus nerve. So they're right next to each other when it handles sympathetic and parasympathetic, and they run along the same plexuses. So you do have a pulmonary sympathetic plexus, a cardiac sympathetic plexus, etc. In there. Now this is rest and digest. So the vagus nerve, when it handles the heart, it actually slows down the heart rate and reduces force of contraction of the heart because you don't need as much oxygen to the body. It constricts the coronary arteries. What that means is it's less blood flow, less blood volume, I should say, of the heart. So you're decreasing the oxygen carrying capacity to the heart because you don't need as much blood to the heart during this time, which is why the coronary arteries constrict. It's counterintuitive. Sometimes you would think when constriction happens, it increases pressure. That is true. It increases velocity, but you're also decreasing volume. So that's one reason that happens. As far as trachea and bronchi, they constrict when the parasympathetic kicks in. So that's a bad thing if you have a parasympathetic reflex and someone has asthma. It can cause more constriction and more issues. Now, as far as the recurrent nerves, let's go over the anatomy first. On the right side, the right recurrent laryngeal nerve is going to come straight down off the vagus, and it's going to wrap around the subclavian vein and run right up the body towards towards your larynx, towards your vocal cords. Whereas the left recurrent laryngeal nerve, as the vagus comes down the left side, it will wrap underneath the aortic arch and go superiorly to the larynx and your vocal cords. So the right comes down, wraps underneath the subclavian vein and comes up. That's the recurrent. The left recurrent wraps underneath the aortic arch and goes up to the larynx. So let's talk about this. This is a key feature, high yield information for medical school. They ask this question a lot on boards. If you have damage to the recurrent laryngeal nerve, whether it be right or left, it's typically due to surgery. They made a mistake and they cut it. Trauma, tumor spread, very rare, but it can happen. It's like esophageal tumors. They can actually compress these nerves. So because they're going to your vocal cords and your larynx, you get hoarseness, weakened voice. So you start getting hoarseness in your throat. You may have difficulty swallowing because if you recall, the laryngeal nerves are coming from vagus, so they handle the esophagus. So you actually may have difficulty swallowing. We call that dysphagia. Or you can get loss of your voice after the hoarseness, and that's called aphonia. So because all of these handle parasympathetic, they also handle the pulmonary plexus. So you may get a little bit of problems with the respiratory tract, breathing, and so forth in that area. So key feature, because this nerve innervates the posterior cricoarytenoid muscle to the vocal cords, which allows the vocal cords to elongate and shorten, it can paralyze these. So if you have issues, you can paralyze this muscle because the recurrent laryngeal nerve, either left and right, it can paralyze the left posterior cricoarytenoid muscle or the right. And if it does that, you can have all these symptoms, but more importantly, if that larynx or that vocal cord is closed and it's paralyzed and it doesn't open, that glottis, the opening that goes down to your trachea, it can be shut, which means you can have difficulty breathing. So just remember the anatomy. The glottis is the hole that enters that trachea, while the vocal cords, as you saw in the cadaver, are right there. So if you paralyze these muscles and the vocal cords can't work and it is shut or nearly shut, you won't be able to breathe. So it's called dyspnea. It's very horrible, but it can happen sometimes if you ruin these laryngeal nerves. So if you injure both left and right nerves and it causes serious damage, you can actually not be able to talk at all because the laryngeal nerves go to the larynx or the vocal cords, and if both of them are paralyzed, you can't talk. So you actually become mute. Okay? Additional problems may emerge during healing, as the nerve fibers that reanest the most, they actually can cause vocal cord motion impairment, and then of course you can get uncoordinated movements of the vocal cord. So that's a problem also, but the main key features is what I have in bold. Alright guys, I'm going to stop here. I'll create a new video for the second half of this lecture, but just review this material over and over and it'll help you for the exam. Okay?